Welcome everybody. This is CardioRisk wave number 13. I hope you enjoyed the previous CardioRisk waves. Today, I would like to thank Amgen for their continuous support to the CME activity of IAVA Society, especially the CardioRisk waves. Also, I'd like to thank ICOM for the technical support and professional arrangements. Today, I have with me two distinguished speakers, Professor Hani Raghi from the National Heart Institute and Professor Ihab Ataya from Ain Shams University. As you know, we are in the era of continuous aggressive lowering of LDL cholesterol, and not only lowering of LDL cholesterol in those who have cardiovascular disease or those at high risk, but even starting to risk assessment of our young population, trying to detect those at risk earlier in life. I would like to introduce the first speaker, but let me first have a 30-second break, after which Professor Hani Raghi will present about the LDL causality, the earlier the better. 30-second break, and please be with us.
Okay. Good evening. Professor Ashraf, do you want me to start straight away? Okay.
Yeah, please.
Yes. Good evening, everybody, and welcome to the Egyptian Association of Vascular Biology and Atherosclerosis, the IAVA, continued education webinars. And I would like to thank Professor Ashraf Rida, who in spite of not being an old man, is the new modern father of Egyptian lipidology since the days of the Lipid Day in Ain Sokhna, where we got our act together, and now with the EAVA. And of course, I'd also like to thank my colleague, my co-speaker, Professor Ihab Ataya, who's a dear friend and a true expert in the field. I'd also like to thank Amgen for sponsoring the symposium, and ICOM for the excellent technical support. We'd like to talk about LDL cholesterol in cardiovascular disease and importance of lipid management. Professor Ashraf Rida just mentioned something very important. Actually, I'll show it to you in my last slide, then I'll go up again. Because I just changed my slides. Look at this. This is a slide that Professor Ashraf Rida and I have been just discussing. It has nothing to do with the presentation today. But this is just to look at a patient, a young person whose LDL is 200, or another one whose LDL is 125, or another one whose LDL is 80. And we're now looking at their lifelong cholesterol exposure in the same way. We're going to give you a whole presentation about this in the near future, but this is just the slide today. But we look at it like we say patient pack years. So when we talk about smoking, we say patient pack years. We don't say they smoke 20 cigarettes a day, because maybe they just started smoking 3 months ago. But when we want to talk, we want to know how many years did they smoke. And that is exactly now, we talk about the level of exposure of over a lifetime. So we actually talk, say, 500 milligram years, or 5,000 milligram years, or 8,000 milligram years. And that is the cumulative LDL exposure over the lifetime. And I don't want to go into exact detail of how we calculate it. But this is the age at which the risk of myocardial infarction will begin to rise. For the patient with an LDL of 200, the age of which their myocardial infarction is going to begin to rise is the age in their 20s. While for this, with an LDL of 125, it will be in their 40s. While for their third luckier friend with an LDL of 80 is going to be in their 60s. And as Professor Ashraf Rida just said, we are going very soon to move into an era of not waiting for this young man to get his first myocardial infarction at the age of 25 and then starting to treat him. But we're going to try and intervene here when this patient is 15 years old, and we're going to try and stop him of getting his first MI. Okay? This is the age at which the risk begins to rise. This is the age where they actually get the infarction. So this patient is probably going to get his infarction at an age of 35. We'd like to start intervening here at the age of 20 before his infarction risk rises. However, we are not in this era yet. This is a dream era, which we haven't reached yet. At this point in time, unfortunately, we're still even not able to help those who've already got their first heart attack. And that is the essence of my talk today. The essence of my talk today is reducing risk in people with already existing coronary artery disease in whom we're not doing very well, which is a shame. And then maybe after we do that, we'll go into the dream of primary prevention. So I would like to say that LDL lowering correlates very well with relative risk reduction in cardiovascular events. So with each 40 milligrams reduction LDL, you get a significant reduction in events, in event rates. 23% reduction in major coronary events and 21% reduction in major vascular events. And the absolute reduction in LDL is linearly related to reduction in the incidence of both coronary and vascular events. And this is a very famous slide, which is looking, if you look at the little fine print here, it's basically every lipid trial. And when you lower the LDL, the more you lower the LDL, the more the risk goes down. So there is basically no lower level. You need to go to zero, okay? Reducing plasma LDL level with a statin led to a dose-dependent reduction in the risk of major atherosclerotic cardiovascular events, which was proportional to the success of your statin in reducing LDL. And that is why all the guidelines have stopped telling you, well, look at tests and do this. They just tell you, use high doses of statins, only use those particular statins because they're the only ones that work. Stop using small doses of older statins because they basically, it doesn't work. I mean, what works is giving patients high spot tolerated doses of statins. I'm talking about high-risk patients, okay? Patients with increased or with existing coronary artery disease or vascular disease. So you just have to give them high doses, take them as low as you can. Don't waste time. And the risk of those cardiovascular events does not stop at any particular number. If you go below 70, the risk continues to drop. So the risk gets lower even very quickly at the 4th week. So cardiovascular death, myocardial infarction, stroke hospitalization, or coronary vascularization just drops as you drop your LDL below 70. And again, cardiovascular death, MI, or stroke, very, very hard endpoints. Again, go below 70 and your risk just keeps dropping. Bring the LDL down to 25. And the proportional relationship between the atherosclerotic burden and the very low levels of achieved LDL, what actually happens is that the mean atheroma regresses. I mean, the dream of atheroma regression exists. We knew that from the asteroid and other trials, which have shown us that with very high doses of rosuvastatin, with 40 milligrams rosuvastatin, atheroma inside the coronary artery, as checked by IVUS, actually shrinks. It shrinks, okay? You can treat those patients. It's almost like, I call it, a stent is like fast food, and reducing atheroma is even better. It's like slow foods, okay? It's healthy. It's much healthier to get rid of the coronary stenosis and avoid future coronary stenosis. So that's what you do, and that's the data we got from the Glagov trial. Look at the mean atheroma percentage reduction with the online treatment LDL. The lower you go, the lower the size of your atheroma goes. Now, Professor Ashraf Rida mentioned our dream of treating young people before they develop coronary artery disease. And that was my first slide. But I'd like to show you that we actually are totally failing. We're failing miserably because our high-risk patients, despite lipid-lowering therapy, a large percentage, a substantial percentage of those high-risk patients are not reaching the target, even a target of 70. So coronary heart disease and acute coronary syndrome patients in a multinational prospective observational DICES study, we've seen that all patients, 29%, ACS cohort only 18.9%, and patients on lipid-lowering therapy are still failing to reach the targets. And of course, who are not on lipid-lowering therapy, the percentage reaching targets are miserable. So these are the percentage reaching the target on treatment. But only 30%, less than 30%, only a quarter of our patients of acute coronary syndromes who are treated by doctors sitting in their offices looking really smart and failing. Okay, 1/3 of high-risk patients and a quarter of ACS patients only achieve the targets. So you're basically giving the patient a pill, costing the patient money, costing society money, letting the patient swallow the pill. The patient thinks they're protected, but they're not protected. They're badly treated. Even those receiving high-intensity statin therapy, the residual risk still remains high for the patients not achieving the target LDL levels. So if you achieve an on-statin LDL, these are 4 randomized controlled trials, meta-analysis of 4 randomized controlled trials of high-dose therapy. The distribution of achieved, the blue line, the distribution of achieved on-statin LDL level, and this is the risk of major cardiovascular events. So 40% of the statin trial participants, and these are not like the patients you see in your clinic, because these are seen very regularly and are tested at a very high level, and the patients are very compliant with medications because they're in a trial. And yet 40% assigned to high-dose therapy did not reach an LDL concentration below 70. And mind you, now we have the new targets of 55 and 40. You can imagine that this number is probably going to double. So again, you give the patient the highest dose statin therapy, and then, you know what? You think they're safe, they think they're safe, but then they're going to get another event because then a lot of them are still poorly treated. And this high LDL level increases the risk across all types of atherosclerotic cardiovascular disease. This is the person years we're talking about. And this is the incidence per 1,000 person years. Coronary artery disease, if you increase the LDL, increases dramatically. Ischemic stroke increases dramatically, so does peripheral arterial disease. The higher LDL, the worse is any type of atherosclerotic cardiovascular disease. So we basically have a very high unmet need, which is recurrent cardiovascular events. And, if you see a patient in your clinic and you say, oh, my patient has already had 2 myocardial infarctions and a stroke, or had already had a 1 MI and 1 non-STEMI, this is a failure of treatment. This patient should not have had, this is like a plane falling twice. It just shouldn't happen. So in the short term, post-myocardial infarction patients are actually at the greatest risk of recurrent cardiovascular events and death. If you look at the patient in blue line, those are the ones who did not have MI or prior history of coronary artery disease. The ones in yellow, no prior history of MI, but prior coronary artery disease. The ones in red are the ones who've already had 1 MI before. And the adjusted post-discharge survival is the worst in the people who've had a second heart attack after already having a previous myocardial infarction. And this shows you, the prior MI with a non-prior MI. And look at this, the very significant increase in death, more infarction, stroke, or unscheduled revascularization. Everything is significant. MACE is much higher in those who've already had the prior myocardial infarction. So again, I'll go to Professor Ashraf Redo's statement at the beginning, which is my dream as well. We both share the same dream. We want to treat asymptomatic people before they get a heart attack. But you know what? We can't even start to discuss that while our patients who've already, as on this slide, had a first myocardial infarction are having a second one and a third one. And you know what? Maybe some of them haven't stopped smoking, which is a disaster, but many of them have. And one of the main reasons is that the cause of their infarction, the severe atherosclerosis, the high LDL is inflammatory. It's still high. We're leaving them untreated. And we must control those patients before we think of anybody else. The recurrent cardiovascular event rate is highest in the patients with prior events occurring within 1 year. So look at this. One of the strongest predictors of a future ischemic events is the previous cardiovascular events. So if you look at a prior ischemic event less than 1 year before the baseline, or a prior ischemic event very remotely 2 or 3 years ago, or patients with stable atherosclerosis but who have not had a prior ischemic event. You look at the numbers. Again, those who've had an acute ischemic event in the previous year do much worse in blue. Look at that. So at least for those patients who already are inside your intensive care unit, who've already had a heart attack, and you're about to discharge them, and you know what? You shouldn't even bother testing the lipid profile inside. You should focus them on maximum anti-lipid therapy, the absolute maximum, to prevent a second event happening in the upcoming months and upcoming year. The same for stroke. This is exactly the same data with stroke. It's reproducible, whether it's for myocardial infarction, whether it's cardiovascular death, whether it's a non-fatal stroke. The strongest predictor is a nearby acute event. This is after an MI. So the recurrent cardiovascular events after an acute myocardial infarction are highest in the first year, okay? And especially in the older patients. Again, this is the time since the index MI, 365 days, 1 year. This is all patients, the interrupted line, patients above 80, look at this. And then 70, 79, 60, 69, and even younger patients. Patients who are event-free 1 year post-myocardial infarction still remain at high risk for future events. And this has been in a recent study in European Heart Journal 2015, again showing the cumulative index for very hard endpoints, myocardial infarction, stroke, or death in stable post-infarction patients from 1 to 4.5 years. Again, it exponentially rises with age. So your patient might look good, might look stable, but you have to calculate the risk very well, and you have to know their lipid profile. And if you are not reaching the targets, your patient is at extreme risk. So, by the way, if you leave your patients as a smoking patient, if you leave a myocardial infarction patient to smoke, it's actually your failure, almost as much as it's the patient's failure. But lipids are almost entirely your failure. More aggressive LDL cholesterol lowering post-myocardial infarction has been studied and has been presented in a recent meeting of the Society of Cardiovascular Computed Tomography, the SCCT. It is very interesting because it found out that 40% of patients were not on a statin therapy before a myocardial infarction, and after a myocardial infarction, only 49% of familial hypercholesteremia patients were discharged on a high-intensity statin. That is really, really dismal. And if you look at the LDL cholesterol achieved 1 year post-myocardial infarction, whether you have no familial hypercholesteremia or familial hypercholesteremia, where the targets are different, it is the rates are poor. And we have the tools to fix this. Okay, so I would like to mention that sometimes you cannot treat the patient properly because of reasons outside your abilities. For instance, medicines are not available, or you're giving the patient medicines that are not working, or the patient is not taking the medicines, or the medicines are too expensive and the patient is uninsured. But if none of these exists and you're treating the patients poorly because of your incompetence, that is something that you should really, really look at. And I'm talking about myself as well. I mean, if there's no reason for us not treating patients properly and we're just leaving them at those dismal figures, we have to worry. This is the guidelines. The guidelines are super clear. The recommendations for pharmacological long-term management after STEMI, excluding antithrombotic therapy, and of course, it recommends statins for everybody. And they want you to reduce LDL by more than 50% from baseline and achieve an LDL of less than 55. That's an after myocardial infarction. If the LDL goal is not achieved after 4 to 6 weeks, combine with ezetimibe. So you only have 1 month to 1.5 months, and you have to test. And if the patient hasn't reached the goal, go to ezetimibe class 1. If the LDL is not achieved after 4 to 6 weeks, that's basically 2 months from discharge or 2 or 3 months from discharge. Despite maximally statin therapy and ezetimibe, the addition of the PCSK9 inhibitor is recommended, class 1, again, level of evidence B. So this is no joke. You can't leave the patients on a physician inertia. In patients with, if you're worried about the costs, you have to remember that the second procedure is very costly. And it's not only costly in dollars or pounds, it's actually costly in human life. The number of second procedures which are done for patients, whether they are cardiac catheterizations, PCI and stents, or bypasses, because of poor initial treatment and failure to correct risk factors is huge. And recurrent cardiovascular events are more expensive than the first ones. So a recurrent myocardial infarction or recurrent PCI or recurrent bypass, even cost-wise, is more expensive than the other. And of course, the human cost is unmeasurable. So how low can we go? Is it safe to let those patients go down to LDL levels below 50 and even below 20? Clinical efficacy and safety of achieving very low LDL cholesterols with a PCSK9 inhibitor, evolocumab, this is a pre-specified secondary analysis of the Fourier study published in 2017. And it showed that those patients who achieved any particular level of LDL, especially the very low ones, here below 25 and below 50, remain stable. This is not a temporary treatment. Those patients just remain at their level of LDL, fixed level. After a while, you don't even need to test them anymore. And the more successful you are in reducing the LDL, the better you're going to get in reducing the primary and secondary composite endpoints at 4 weeks. So if you go to the LDLs below 25 or below 50, these patients do extremely well in both the very hard endpoints of cardiovascular death, infarction, or stroke. The ultra-low LDL, so patients with LDL less than 10 or less than 15 had great improvement in events and did not have, there were no difference in serious adverse events. There were no difference in adverse events leading to drug discontinuation. So low LDL was fine. It did not, we know from the Ebbinghaus study, there was no mental issues related to low LDL. The brain can keep keep the level of cholesterol it needs. It has its own mechanism at control, and patients who had an LDL less than 20 had absolutely no neurological issues, no brain issues. So the relative efficacy of lipid-lowering treatments, there's a new network meta-analysis, very new from American Heart Association 2020, and they looked at the relative efficacy of alirocumab, bempedoic acid, evolocumab, ezetimibe, and inclisiran added to statins for reduction of LDL, and it was a network meta-analysis of randomized clinical trials by Peter Toth, the president of the American Society of Preventive Cardiology, and his colleagues presented as an abstract. And the background was that reducing LDL levels is important, and that the clinical guidelines in both the United States and Europe have been revised in recent years, recommending lower LDL goals for very high-risk patients because these goals were not previously attainable and are difficult to achieve with statins alone. And it looked at non-statin agents combined to statins to optimize the LDL cholesterol reduction, and especially following introduction of the monoclonal PCSK9 inhibitors, alirocumab and evolocumab, and bempedoic acid and inclisiran, which works on the PCSK9 via the RNA. And recent European data has shown that among very high-risk patients, 39% achieved their LDL cholesterol based on the guidelines. And when the guidelines were changed, only 18% of high-risk patients achieved the targets. And the use of ezetimibe and PCSK9 inhibitors was low. So in this network meta-analysis, NMA, was assessed the relative efficacy of different non-statin agents for reducing LDL cholesterol. And the network meta-analysis looked at LDL reduction at week 12, or the nearest point time. I don't want to go through the statistical details, but this is the patients with hypercholesterolemia receiving moderate to high intensity statin or who are statin intolerant, receiving the huge treatments in different doses. So, for instance, the monoclonal antibodies, alirocumab, 75 milligram every 2 weeks, 300 milligrams monthly, or 150 milligrams by every 2 weeks. Evolocumab in its famous doses, the most famous is the 140 milligram every 2 weeks, or 420 milligram monthly, compared with placebo. And then the outcome was the LDL measured at 12 weeks. They looked at records from thousands of patients and excluded poor studies. I don't want to go through the methodology. This is the network diagram. Again, is the doses I just mentioned to you. So, and they looked at all the important trials. For instance, for inclisiran, they looked at Orion 1, 9, 10, and 11. And for evolocumab, they looked at Fourier, Glagoff, Laplace. They looked at everything, okay? For alirocumab, they looked at the Odyssey trials. And, sorry. And that was it. Evolocumab was the most effective. Both the evolocumab and alirocumab were most effective in reducing change in LDL from baseline to placebo, immediately followed by inclisiran. Of course, ezetimibe and bempedoic acid were less effective. The most efficacious agents were evolocumab, 140 milligram twice weekly, or 420 a month, and alirocumab, 150 milligram twice weekly. So these were the most effective. Please note that the alirocumab 75 milligram twice weekly was less effective. These two were as you would expect, were the two most effective, and minus 64 reduction in LDL compared to placebo. And this was on top of statin background therapy. This is just a reflection of the previous trial. So, and the same in a small number of statin intolerant patients, you got the same results. Because some of the Asian population had to be taken out of the studies for side effects. So if you exclude the familial hypercholesterolemia patients, you exclude the East Asian studies, you get consistent results with network meta-analysis. So this is very, very reproducible data, and is data to be trusted. And the conclusion that all non-statin agents were efficacious for reducing the LDL cholesterol level, but of course the monoclonal antibodies PCSK9 inhibitors, evolocumab 140 milligram twice weekly, or alirocumab 150 milligram twice weekly, were consistently the most efficacious, with bempedoic acid and ezetimibe least efficacious. Those findings were consistent regardless of statin background therapy or statin intolerant patients, and even sensitivity analysis excluding familial hypercholesteremia studies and studies from East Asia. Those most efficacious dosing regimens should be considered for very high-risk patients in which the LDL is not adequately controlled with maximally tolerated statin therapy. This was my last slide, and I would like to thank you very much. And I know we're probably going to take questions at the end, but I give the microphone back to Professor Ashraf Rida. Thank you very much.
Yeah, thank you, Hani. Actually, I think the word LDL causality is very important because I know that most of us know that LDL causes atherosclerosis. However, there is some even physicians that doubting this wording, and they say that okay, if a 55, 60 years old man, smoker, obese, bad lifestyle, got an atherosclerosis, this is may not from LDL cholesterol, maybe from the risk factors. So I think your answer about this question is very important, and I want to add to those still in doubt that yes, risk factors is very important, can cause atherosclerosis, but however, if you look at the case of homozygous familial hypercholesterolemia, for example, a small young boy at the age of 12 or 15 with myocardial infarction, just because of he has very high LDL cholesterol. So this is a direct evidence that LDL cholesterol, even alone, can lead to atherosclerosis. This is number one. Number two, we are doing a bad job because we are not controlling our patient adequately. The goals of therapy is not achieved in vast majority of patients. I don't know why. Maybe we are not discussing with the patients the issue of LDL goal, LDL target, because most of these high-risk patients need a very low target of therapy, which even could not be achieved with statin therapy alone. I want to ask you, if you find a high-risk guy, for example, post-myocardial infarction or whatever the cause of, he is very high risk, and his LDL, for example, is 140 or 150. Why not starting combination therapy from the start? Because, you know, especially in Egypt, if we give statin therapy, you may lose the patient in follow-up. So why not cut the long story short and start statin and ezetimibe, at least to bypass one of the steps towards the achievement goal? Do you recommend that? I know the guidelines say statin, then ezetimibe after 1.5 months. What's your opinion about that?
Thank you, Professor Rida. This is a very important question. I'm going to tell you my personal practice. My personal practice is if I get a patient who develops an acute coronary syndrome, who's at an extreme risk of the spectrum. So the patient has other vascular lesions, which I have seen, which do not need correction at the time with stents. The patient is diabetic. The patient was a recent smoker. The patient has had already a previous acute coronary syndrome, or the patient is already on statins and is not anywhere near their targets. I actually start PCSK9 inhibitor in the intensive care unit. And what I do is after we do the primary angioplasty or the acute treatment is I discuss with the patient and the family their guidelines. I explain to them that this is a personal opinion of mine, that I believe that an acute reduction in their plasma lipids will be helpful. We have enough data, but that it's not necessarily 100% guideline based, that guidelines say they should wait. I check the logistics, the financial logistics, which is very important. So if the patient clearly either has no financial limitation or is covered by a cooperative insurance, because I do communicate with the insurance and I explain my rationale, because it's very, very important. I'm going to be very frank with you. It's very, very important that there is absolutely no question marks as to why I'm doing this. It's only the interest of my patient. So I don't want there to be any hanging shadows from other parties like the patient's insurance who might think I'm overprescribing. So I actually do it on a very personal level for every single one of my patients. And let me tell you that the majority of my patients, not the majority, all my patients who've had an acute myocardial infarction in which there's no financial constraint for a PCSK9 inhibitor, leave the intensive care unit on a PCSK9 inhibitor. And I do two other things. I give them the first injection myself to teach them how to do it. And I offer to give them every single injection free of charge if they just drop in every couple of weeks, because I think that is one way which we're going to guarantee compliance, 100% compliance with lipid-lowering therapy, which, as you know very well, has been our dream. Our patients are at best less than 50% compliant. But if we give them the injections ourselves, and you know, when inclisiran comes, this will even be twice yearly for some patients. So that is what I do. You asked me about my practice, and I'm very careful to explain that I'm doing this because I feel I have enough evidence. I'm an old man. Maybe the guidelines will change completely in 5 years. Maybe I'll be dead by then or practicing. I want to give my patients the best chance now. I don't do this to please a pharma company. I don't do this for anything except what I looked at the data and I'm completely convinced. This is what I feel.
So at least I can agree with you that if we find very high-risk patients, post-MI or whatever, and his LDL cholesterol is elevated, so that I am not expecting that high-intensity statin will go to 50% reduction or 55 milligram per deciliter. At least we can start combination high-intensity with ezetimibe first, rather than starting statin alone. Dr. Ihab, any comment or question?
I agree very much with what Dr. Hani said, because these are very high-risk patients, and you can't risk waiting for a secondary event. So you have to do the calculation, like, you know, expectedly which combination of statin and ezetimibe will reduce 50%, which will give you 60. Some will even give you 70 if you put, for example, something like Rosuva 40 with ezetimibe. So if you know that you can use these agents and get to target, well and good. But if that patient is way off, way higher than what these combinations will achieve, then you're inclined, in my personal opinion, especially for a high-risk patient, to go ahead and add a PCSK9 inhibitor.
Okay, so I think we can take a 30-second break to be ready for the next presentation. Okay, be with us. Again, in the next part of our CardioRisk Wave today. I'm glad to introduce my dear friend and colleague, Professor Ihab Atiyah, Professor of Cardiology at Shams University. And Professor Ihab now will present to us the earlier the better, but in another prospect. It is not the earlier the better, meaning that starting at young age for primary prevention. But I think from the presentation title, this is earlier the better in hospital patient with acute coronary syndrome. So I think this is very important questions. What should we do in patient with acute coronary syndrome and myocardial infarction? And what data we have about using aggressive lipid-lowering therapy in such patients, and what goals of therapy is there, and especially what is the evidence of Evomab in context of acute coronary syndrome. Professor Ihab Atiyah,
thank you very much, Professor Ashraf. I really must say that I enjoyed Professor Hani's presentation. Was really including a lot of new data and quite interesting. Going to my subject today, we're talking about these very high-risk patients who have an ACS. And should we start earlier, and is the earliest the best? Could we start in hospital initiation of such powerful agents like evolocumab? Well, to start with, we have to think about where does the scientific evidence of lowering LDL cholesterol in patients with ACS come from? We all know that the data comes from the large statin trials. We have namely 5 adequately powered statin trials that gave this data, so that the guidelines now are recommending initiating high intensity statin to patients with acute coronary syndrome. And the important thing is that it's not only LDL lowering with these statins. At the time, they were very impressed with the pleiotropic effects. You all know the plaque stabilization, the anti-inflammation, the antioxidant effects, as well as some antiplatelet effects, in addition to the increase in adiponectin. All these pleiotropic effects we were accustomed to, even improving endothelial function. So these were things that we were very happy with, the statins beside the LDL reduction. So let's look very quickly at these 5 trials. The first, you all remember the miracle study comparing high intensity statin like atorvastatin 80 with placebo. And this was one of the first trials to show that there is a value there with the impressive relative risk reduction that occurred in this trial at the time. This was one of the new things, and it stayed for a while that only atorvastatin 80 was used initially. I remember the residents in the coronary care unit, they used to prescribe it immediately upon admission of patients with ACS without even going back to the attending physician. Also, the PROVE-IT TIMI 22 trial, as we all remember, comparing intensive using atorvastatin 80 compared to moderate using pravastatin 40 lipid-lowering statins after acute coronary syndromes. And again, it showed an impressive reduction in death or major cardiovascular events. So this was, again, another trial. And the third trial, if we remember the A to Z trial, and you look especially at the phase Z of that A to Z, which studied the early intensive versus delayed conservative simvastatin strategy in patients with ACS. And again, that was the third trial. The fourth trial, you all remember, not only a statin trial, but adding ezetimibe to simvastatin, the IMPROVE-IT study, and we are all aware of the results of the IMPROVE-IT. And that's what made the guidelines, especially the American guidelines, change their idea about only statins by adding non-statins in addition, such as the combination with ezetimibe after ACS. And finally, the fifth trial was the Odyssey outcome trial with the monoclonal antibody for PCSK9, alirocumab. And you all remember the absolute relative risk reduction of 1.6%. So these were the 5 trials that had been adequately powered to show data. Of course, there are other trials in Japan that showed other results impressive as well, using lower doses of statins, because, you know, in the Japanese and the Asian, they respond quite well to lower doses of statins. They also showed that after ACS, these statins cause plaque regression. And when they did an extended follow-up for these patients, they found not only plaque regression, but also reduction in cardiovascular outcomes in their Japanese patients. All this made the ESC dyslipidemia guidelines in 2019 change. When you look at the different risk categories, and you look at the ones we're talking about today, the ACS patients, they are the ones on the right, the very high risk, and these are the ones where you should reach a goal of less than 55 milligram per deciliter and a reduction of 50% or more from baseline in LDL. And this very ambitious goal they put for the patients with residual very high risk, these that develop a secondary atherosclerotic cardiovascular event within the last 2 years, even if it's different than this index event. And such very high-risk patients, they put a goal that is below 40 milligram per deciliter, quite impressive. Again, these are the updated treatment goals. You're all acquainted with them, and you know that, like I said, in the secondary prevention now, the LDL has to be less than 55 milligram per deciliter, in addition to a reduction of 50% or more from baseline. But what was really new for us, again, besides the 55, was those patients at very high risk, like I said, who have a second event within 2 years with an ambitious goal of below 40 milligram per deciliter. And these, at the time, were very, very shocking numbers when it was published in 2019. A lot of physicians were very shocked from such very low figures. However, not only that, but this is what I'm trying to pinpoint at, is that we look not only at giving PCSK9 inhibitor to patients with stable atherosclerotic cardiovascular disease, but what about when you get an ACS patient admitted to your coronary care unit, and that ACS patient is already receiving a high-intensity statin with ezetimibe? He was treated with another cardiologist, who gave him high-intensity statin and ezetimibe, and despite that, he developed an ACS. And when he came to your coronary care unit, you found that the LDL was not at goal. And then this is where the guidelines say you can add a PCSK9 inhibitor even after immediately diagnosing this event, if possible, during hospitalization for that same event. And this should be considered. And this, to me, again, was very new information when I saw it, and I even discussed it with some of the participants in putting these guidelines, and they said, yes, why should we wait for getting another event like Dr. Hani said? Because if you leave such a high-risk patient who already developed an ACS while taking high-intensity statin and ezetimibe, he's going to get it again and again. So you need to go lower, and this is where you should add a PCSK9 inhibitor. Let's look at the core of my presentation today. Is like Professor Ashraf asked, where is the evidence for using evolocumab in hospital in such patients with ACS? Well, we'll start with, if I'm going to discuss just a few studies, starting with the EVO study. You're all familiar with the EVOPAX study, which is a really good study. And what this study did is it looked at the background. They looked again at the PROVE-IT study, but they looked at the very first 30 days in the PROVE-IT study. The very first 30 days when they compared Prava with atorvastatin, and they got an impressive relative risk reduction of 28% as early as 30 days. So that was very impressive, meaning that you should start early. And this is why, when you look at the recommendations down the guidelines, it says it's recommended to initiate or continue high-dose statins early after admission in all ACS patients without contraindication or history of intolerance, regardless, the key word is regardless of the initial LDL values, whatever their LDL values are. And this, again, was mentioned by Professor Hani Raghi in his previous presentation. So they thought the monoclonal antibodies, the PCSK9 monoclonal antibodies, will result in a rapid, profound LDL reduction. And this was shown in patients without atherosclerotic cardiovascular disease, as well as those with stable established coronary artery disease. So they said that these evolocumab has not been tested in the acute setting of ACS, a clinical setting that has the highest risk of recurrent events early on. And it was a challenge because against a background of the pleiotropic effects of statins and non-statins like ezetimibe, like I said, they have pleiotropic effects on inflammatory biomarkers, platelet reactivity, prevention of contrast-induced acute kidney injury. So how will the PCSK9 antibodies fare versus such a pleiotropic effect? So let's go again to the timing of the study. When we look at the PCSK9 inhibitor trials, when you look at the Fourier, you all know it wasn't a strict ACS study. It actually studied patients that had stable coronary artery disease 1 to 7.4 years after the MI, the index MI, and even the Odyssey outcomes, which is a post-ACS study. It studied the patients from 1.7 to 4.4 months after the index ACS. But what about the very early days after the ACS? This is what I'm talking about today. And this was the study hypothesis. They said, what if we use evolocumab and give it as early as 1 to 3 days post ACS after the index event, and to see if it's going to be well tolerated and will result in greater reduction of LDL levels at 8 weeks compared with placebo. And placebo, this is in patients that already are receiving high-intensity statin treatment. Even the placebo patients are taking high-intensity statin treatment. The endpoints were simple. The primary endpoint was a percentage change in LDL from baseline to 8 weeks. And the secondary endpoint was safety and tolerability. And there were few interesting exploratory endpoints to look at, which were the inflammatory biomarkers, the high sensitivity, C-reactive protein, platelet reactivity, contrast-induced acute kidney injury, as well as post-PCI myocardial injury. And this is the study design. We look here, we see that the patients that had STEMI were already randomized less than 24 hours, quite ambitious. Before 1 day, they were already randomized in the study. Those that had ST elevation ACS were randomized less than 72 hours, and the LDL at screening, the values that were above 70 on high intensity statin and those above 90 on moderate intensity statins and those above 120 milligrams on no statins at all. These were randomized to receive either evolocumab 420 milligrams once, and this is available in the United States, as you all know, that dose, versus placebo, both of them on the background of atorvastatin 40 milligrams daily. And the primary endpoint was assessed by measuring the fasting blood lipids, and the exploratory endpoints were also checked for whether for inflammation, platelet function, etc. And this was for 8 weeks. You look at the baseline characteristics were equally balanced between both groups, as we can imagine. They were equally balanced. And looking at what type of ACS events happened at the index ACS, 37% presented with STEMI, while 63% did with non-STEMI. And of course, those that were STEMI were randomized less than 24 hours. That's 100% of them, versus 39% of the non-STEMI were randomized within 24 hours. The rest, 61, were randomized less than 72 hours. And these ACS patients received PCI, 84% of them, 7% had CABG, and 9% only had medical therapy. When we look at the results, and we look at the statin treatment, let's start with the statin treatment at baseline. Those that had no statins, and you find a very high LDL at baseline, which was around 145 milligram per deciliter, and those that took a low to moderate intensity statin, again, it's rank around 115 milligram per deciliter, and those that received the high intensity statin, those had almost 90 milligram per deciliter. These were at baseline. When you look at the primary endpoint, which is the percentage change in LDL at 8 weeks, you find an impressive reduction of 40% as early as week 4. As early as week 4, we find that the PCSK9 brought down the LDL to a mean of 31 milligram per deciliter compared to 77 in the placebo group, and it was maintained to week 8, again at 31 milligram versus 80 milligram in the placebo group, and this was quite impressive. Okay, if you translate the figures to the percentage of patients who reached the targets, Well, it depends which target are you looking for. If you're looking at the targets of the American guidelines, which still say it's okay to go less than 70 milligram per deciliter, you find that the ones that received evolocumab, 96% of them reached the target compared to 37% of the placebo group. While if you look at the ambitious European targets of reaching less than 55 milligram per deciliter, there were 90% achieving that target compared to only 10% of the placebo group. Again, and look at the subgroups and see which group benefited. We find that most groups benefited. Depends whether the clinical presentation was STEMI, non-STEMI, it's still the same. The age above 65 or below, the gender, male or female, all of these showed benefit. The ones that showed a little bit more benefit were, of course, as expected, the ones that received statin compared to those that had no statin at baseline, and this is understandable. This was only the only one with a p-value of 0.001. Looking at safety of using such a powerful drug like evolocumab as early as 1 to 3 days, it's important to look at safety, and we look at the p-values, there is no difference between it and placebo. Look at whatever you want to see, the liver enzymes, allergic reactions, whatever. So it was very, very similar, which gives reassurance about safety. The other point is the exploratory endpoints that they tried to look at the inflammatory markers, the platelet reactivity, renal function, post-PCI myocardial injury. Actually, there was no significant difference between the placebo and evolocumab, no significant difference, no much difference there. And the p-values were non-significant for any of these. So in summary, the researchers found that these ACS presenting patients with elevated LDL, when they had an early in-hospital initiation of evolocumab on top of high-intensity statin therapy for 8 weeks, they reached an impressive LDL level of 31 milligram per deciliter compared to 80 milligrams per deciliter with statins alone. More than 90% reached the recommended ambitious targets of the European Society of Cardiology. Only 11% of placebo reached this target. It was safe and well tolerated during this short duration. However, it did not result in any measurable difference in the surrogate endpoints, like I said, of inflammatory biomarkers, platelet reactivity, acute kidney injury, or myocardial injury. The next study I'm going to share with you today is the EVAX study. These are results from the EVAX study. Again, it's a placebo-controlled randomized trial looking at the effect of evolocumab on atherogenic lipoproteins during the peri and early post-infarction period. And the design of the EVAX was a double-blind, one-to-one randomized placebo-controlled trial. These patients had a type 1 non-STEMI with a troponin I 5 nanogram per milliliter or higher. The endpoints were change in LDL at 30 days, day 30, and the second endpoint was the change in other atherogenic lipoproteins. Again, we see that it was early randomization, 24 hours. This is quite early. And these patients received either evolocumab 420 milligram one dose or placebo. And these patients were followed up for 30 days after hospital discharge. And let's see what were the baselines in these EVACs. We find that there was no much difference in baseline except for the differences in sex, maybe between evolocumab, higher male proportion compared to placebo. But when you look at the intensity of statin therapy or the baseline values of LDL, they were quite similar between both study groups. And importantly, how early did LDL levels decline after taking a single injection of evolocumab? When you look at the line graph, we find that as early as day 1, just 1 day after the injection, you find that there was a reduction in the LDL value to 70 compared to 86. However, it reached statistical significance at day 3, reaching a p-value of 0.02. As early as day 3, there was already statistical significance between both arms with 49 milligram LDL compared to 76. And then this maximum reduction happened between day 4 and 7, reaching 31 milligrams compared to 75, and it was maintained until the 30 days. So this showed that there was a significant reduction throughout hospitalization and even 30 days later compared to the statin alone group. Were the patients who were treated with evolocumab able to reach the targets and the recommended guidelines, whether it's American or European? When you look at the ones that reach less than 70, fulfilling the American guidelines, we find that about 80% receiving the evolocumab reached that target, compared to only 38% in blue that reach this target right here. However, the European target, we find that around 65% reached the target compared to only 24% with the statins. So this was, again, very impressive. This is at the time of hospital discharge, which is early as 4 days. So as early as 4 days, you have 80% reaching the American targets and 65% reaching the European targets. What about safety, incidence of adverse events and serious adverse events? And were they similar? Yes, whether the serious or any adverse events were similar between the evolocumab and the placebo groups, no much difference there. I will turn now to the last study I will share with you, which is an important study. These are new data coming out from the Fourier study, and they looked at the patients who had a recent myocardial infarction, 1 to 12 months, and they saw the benefit from evolocumab in these patients. So they studied, the analysis in this study was for the patients only with recent myocardial infarction, and it was presented at the American Heart Association again last November 2019. And when we look at the important point in the baseline characteristics, we have a group that had a recent MI with a median time of 4.8 months from the index MI compared to a remote MI, which was a mean of 59 months from the index MI. Otherwise, you find that more or less there was difference, of course, because of the higher risk of these patients with the recent MI between these groups. Let's take a look first at how risky it is to have a remote MI compared to a recent MI. Definitely, a recent MI is much riskier because if you look here at the 3-year event rate and you look at the group that had a recent MI in orange and you find the events were 17.2 compared to the ones remote MI only 14.4. Even the incidence of the secondary endpoints again was higher with the recent MI reaching almost 11% versus 9.5% with the remote MI. So this tells us that the recent MI, that's a special high-risk group of patients that we need to really help as early as we can. Well, let's look at what evolocumab did for this group of patients. Let's look at those with the recent MI group, the ones, like I said, 17.2%. Eventually, compared to that, we had an absolute risk reduction of 3.7%. And a number needed to treat as low as 27. So we had a relative risk reduction of 19% in this group of patients, while in the remote MI, the absolute risk reduction was 1.1% with a relative risk reduction of 8% in these patients. Well, let's look at the secondary endpoints of cardiovascular death, myocardial infarction, and stroke. And again, you find the same thing, a little bit more impressive. You find an absolute risk reduction 3.2% and a 25% relative risk reduction with evolocumab in those with recent MI, while those with remote MI, it was relative risk reduction 15% with 1.3% only absolute risk reduction. So the number needed to treat with the recent group is 32, while the number needed to treat was 79 in the remote. So there's a difference. There's a real difference, real benefit for those with recent MI compared to remote MI. So in summary, they summarized this trial that patients with recent MI are at higher risk of major adverse cardiovascular events compared with those with a remote MI. And like I just said, in the recent MI patient group, evolocumab reduced the risk of the primary endpoint by 19%, with a number needed to treat of 27 over 3 years. And the second endpoint of cardiovascular death, myocardial infarction, stroke was reduced, a relative risk reduction of 25% with a number needed to treat of 32 over 3 years. So in conclusion, dear colleagues, again, the important thing is that the guidelines recommend to use PCSK9 inhibitors in patients who present with ACS who are not at their LDL goal while on maximally tolerated statin and ezetimibe. Like I said, if you get a patient admitted to the CCU who's already on maximally tolerated statins and ezetimibe and not at his goal, no need to waste time. You can start it in hospital immediately. And as we saw, the EVOPAX and EVAX trials proved the efficacy of in-hospital use of evolocumab, but the real impressive data came from the inferior recent MI patients, the ones between 1 to 12 months, where the reductions of the primary endpoint and secondary endpoints were quite impressive, like I just showed in the previous slide. This gave us the real benefit, and I think this will be also impacting the guidelines soon. I think so. So in conclusion, I think that these patients, these very high-risk patients, they have to reach their goal. Well, if you can reach it by very high-intensity statin and ezetimibe, and you calculate their baseline LDL at admission, and you decide this is good enough, well and good. But if you know it's not going to do the job, well, you can add the PCSK9 inhibitor and save this patient a second event and save his life. Thank you for your attention.
Thank you, Professor Ehab, for this comprehensive review of the situation in post-acute coronary syndrome, especially as regard the use of PCSK9 and the indication of this usage. So you give us important data, especially that from the subgroup analysis of Fourier trial, post-myocardial infarction. So we have data about the use in the post-myocardial infarction period, whether early or remote, and also we have data from the acute coronary syndrome trial. We know that the most important thing to protect our patient is to achieve the LDL cholesterol goal. And I think many of our patients admitted to the intensive care coronary care unit with acute coronary syndrome, even if they are in statin therapy, there is a high percentage of those patients, I'm sure they will be above the recommended target of therapy or recommended goals. So I'm sure you are talking about a significant number of percentage of patients with acute coronary syndrome who may need really PCSK9 inhibitors in the intensive care. My question is about the issue of high sensitive C-reactive protein. I know that if we look at the design of this study, this is acute coronary syndrome patients who are supposed to have high sensitive C-reactive protein from the start in both groups. And keeping in mind that both groups are on lipid-lowering therapy. Even in the placebo group, they are on lipid-lowering therapy. And the high sensitive C-reactive protein, I'm asking you, it's supposed to going down without anything by time after acute coronary syndrome. So maybe that's why we could not find a difference between the two groups in these situations. And I'm sure that achieving the goal here is much, much more important than looking at high sensitive activity. What is your impact of that?
Yes, this is an excellent point. And the way I look at it is that already, like you said, both arms are on in high intensity statin. So already they got a certain percentage reduction in the high sensitivity C-reactive protein. And then these studies were short studies. These were not long studies to give us more time to see further a reduction in this chronic inflammatory markers. So these short studies, some of them were just very few weeks. So the reduction maybe, if it was a little bit longer, could have shown even more impressive. But the important point is that with the statin and the evolocumab, you did not get any attenuation of that benefit. I mean, if you use them in combination, you're still getting the benefit of the pleiotropic effect in addition to lowering the LDL more impressively. So you're getting both benefits. So we did not neutralize that benefit when you added this drug, because we did not have this information in such patients with acute coronary syndrome and high sensitivity C-reactive protein. Somebody could say, well, if I add such an agent, I might attenuate this benefit. Well, this is not the case. But in other studies with a longer follow-up and with stable atherosclerotic cardiovascular disease, you get a chance to see the reductions more impressively.
Hani?
Yes, thank you. I think you had in the very last sentence just pointed out the point I was going to make. The importance of high sensitive C-reactive protein, like in Jupiter, is actually in stable patients, because it identifies a group of stable patients who are at much higher risk. But once you have an acute myocardial infarction, the bomb has exploded in your chest. So what you really need to do then is to reduce the LDL, because the LDL is very inflammatory. I mean, Bronwald said LDL is toxic. And I don't think, please correct me if I'm wrong, I don't think there are many studies which studied high sensitive C-reactive protein post-STEMI. I think it's not a real issue. The issue is in stable coronary artery disease to identify the riskier patient.
Agree with you, Hani, and I think we now have data according to the Dr. Ihab presentation and your presentation that it is safe to give PCSK9 inhibitor whenever needed in acute coronary syndrome patient. It is safe and it is effective in lowering LDL cholesterol, even as the Ihab presented in the first few days after the acute coronary syndrome. Hani?
Can I ask a question to you and to Professor Ihab and to the audience?
Sure.
If PCSK9 inhibitors were free, so if you have an insurance which is covering all your patients, how many patients with a STEMI would get them on their prescription coming out of hospital? And I would volunteer to answer that probably many of the patients would get them out of hospital.
Yeah.
So if it's just an issue of cost, that is a very important issue, but its cost is not science. So I think the majority of cardiologists that I know are only finding a single barrier between using PCSK9 inhibitors, which is not science anymore, it's just cost.
Have any comments?
Yes, I do agree, and I don't think it's only in the ACS or STEMI patients. Even in our patients who come to the clinics, the one with stable coronary artery disease, if it wasn't for the cost, they would love, a lot of them, when they know that there is an available single injection every 2 weeks that will lower their LDL impressively by 60% without having side effects, and has data, they would like to get it. The only thing, the barrier, like Dr. Hani just mentioned, it's the price. When they hear the price, they go back. So that's definitely, if there was no price issue, it would be written for the ACS, the MIs, as well as the stable patients as well, because the data is there. The problem is when you don't have data and you have an expensive drug, you're kind of worried what to do. But once you have the data, it remains that only the cost is the one that's hampering you from widespread use.
Well, I want to add this, Hani, that if we look at the guidelines and the algorithms of using PCSK9 inhibitors, it should be used in any patients who is not reaching the goal after using combination therapy. And if you look at the patient at the trials of achieving the goals, you will find easily that maybe 60% of our patients, especially high-risk patients, did not reach the goal. In the Cepheus trial, for example, in the very high-risk patients, we reach the goal only in 11% of the patients. So if you are not concerning about the cost, I'm sure there will be at least 60 to 70% of our high-risk patients will need PCSK9 inhibitors, and this is according to the guidelines and according to the algorithm derived of the guidelines. It's not speculation. It is not an expert opinion. That's the guidelines that if not reaching the goal after high intensity and after ezetimibe combinations, you should give PCSK9 inhibitor. So I'm sure the cost is an issue, but this is an answer to Professor Hani questions. I think if you don't have any further comments, Professor Ihab, I can conclude this very nice, educative, and enjoyable session. This is CardioRisk Wave number 13. I hope that all of you enjoy and benefit from the presentations from our experts today. And again, thank you, Amgen, for the support of our CME activity of IAVA Society. And thank you, ICOM, for technical support. And many thanks to all the audience who tolerated us for this.
Thank you all, and stay safe and enjoy the evening.
Thank you. Thank you. Bye. Bye, everybody.